Good evening, everyone, and welcome to Pull Up with Limbs and Things. My name is Dr. Chanel James, and I'm the owner of Limbs and Things, mobile and telehealth physical therapy practice. As always, Pull Up with Limbs and Things is to confirm something you know, to challenge something you don't know, and to give you the opportunity to share that information with someone else. Tonight, we want you to talk to Dr. Jennifaye Brown. She is a stroke specialist, and we're talking specifically tonight about the ankle foot orthosis. So, if you've ever needed a device for your foot, if you've ever been diagnosed with Footdrop or paralysis that affects your lower leg muscles, or you particularly use an ankle foot orthosis, this Pull Up with Limbs and Things conversation is for you. So, please participate. You can put your question in the chat and we'll answer it. But I want to talk to you a little bit about how I met Dr. Brown through the American Academy of Physical Therapy. And she has done numerous courses there through our conferences and provided a lot of information that will help us as physical therapists. But she also does something unique in making sure that she does community-based research. So working with her patients to find the best options for them and doing it in a functional way, similar to what we do at Limbs and Things. So welcome, Dr. Brown. Nice to have you.
Thank you for
How are
having
you?
me. I am wonderful. And I just want to say kudos to you for your work in doing limbs and things and being focused on treatment for and options and getting therapy to people that they may not always be able to provide. I still have my little sticker on the refrigerator that says, limbs and things, and you're leaning out your car like, I'm coming to visit you, I can help you. So I'm proud of you for doing the alternative when a lot of people would not have chose to do. So since you've seen me, I fully retired from academia and clinical practice. I established JVB Physical Therapy Services LLC. I used to be incorporated, LLC now. And my focus is on really doing interventions that help with the quality of the health span as people age. Because I saw a lot of people with stroke across the lifespan, teens, middle age, older adults, and my younger folks are aging. And so now I've had to add in this geriatric component and teach people how your body changes over time and what we need to do to have you be more functional over time. So the braces have changed. They have to support gains and loss in body weight. They have to look a certain way depending on when you're in your 20s and you want to be with the hip crowd versus when you 60s and you going to church and you got to look good in your dress and your hat and you can't wear no black sneaker with no Velcro across the top with your brace. And if you're a socialite and you're the secretary and personal assistant to the CEO, you want your AFO to blend in so it doesn't look odd when you're wearing your your dress. And so I've really become person-centered, but what hasn't changed is the components of cardiorespiratory fitness so that people can age and age well and age healthy. So I'm all about heart health and brain health. And once you put those two things together, when you affect your brain health, you nourish the nerves that are left over from the stroke that can do the function of those that have been damaged. And people really got to work at a high intensity for that. And they don't understand that because our society has dampened the effort in which we have to work to keep healthy. You sit on a bus, you sit at the bus stop, it's closer to your house. You can ride in a cart at Walmart. I'm just waiting for the big box stores to have the length of the aisles and how much they are, and tell the seniors they can come and walk up and down and walking down, because our two malls are not open at 6 to 9 for the walkers anymore. I used to go walking at 6 a.m. at the mall, especially in the wintertime. And you can't walk at the mall now. So I'm all about how I've been telling people, I'm going to measure your house. I need you to walk back and forth in your house. I want you to walk singing Twinkle, Twinkle, Little Star. And then I want you to walk singing Rockin' Robin, because when you singing Rockin' Robin, tweet, 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 you're going to walk a little faster. And that's the intensity change. And then when you get into one room, you're going to turn and you're going to put your foot up on the rung. And then you're going to put your foot up on the seat of the chair 10 times. And then you're going to turn around and walk back to the other side of the house. And you're going to sit down, stand, sit down, stand, sit down, stand 10 times. That's an added layer of intensity. And when you're doing those exercises, you're working the muscles isometrically on one leg, concentrically, and eccentrically. And these are the type of muscle things that you need to keep your flexibility and strength to do functional activities outside of the home, like curb negotiation, up and down stairs and ramps. And so I think people are missing the fundamentals. Oh, I sat down in my chair with my back here and I was doing the exercises. But you weren't, your trunk wasn't engaged and it wasn't rotating. Most people fall when they reach across their body and pull something into them. And they don't know how to lower that weight and accept it with their core, have the muscles work eccentrically and change their base of support with the weight shift of the object. That weight shifting is important to keep the heel mobile for the ankle foot orthosis. So I'm just changing my perspective on how I do this across the lifespan, and then how I do those things for the health span.
Yes. So that's great. That's a lot of what we do too, trying to make sure that people understand you have to change your house into a track or change your house into a gym so that you don't have to worry about barriers to getting out and doing those things in other areas. So let's talk specifically, what is an AFO? And why you're so interested in doing things that are specifically for people post-stroke from what you have experienced.
This is an ankle foot orthosis. It looks very different than the typical off-the-shelf ankle foot orthosis. Ankle means it needs to support the ankle. It needs to support the foot. And the orthosis is just a technical term. This is the shaft portion. So this one is thin, but this shaft portion goes forward on one side, but not on the other side. Why is this so different? Because this person had a stroke and certain muscles of the leg and ankle were weaker versus stronger, as with the foot. The muscles that cross the ankle and attach to the foot may cause the foot to turn out, really be flat, the toes to curl, or the toes stay extended. Most of my braces stop right here so that the toes can get on the ground and push and allow this to happen. Well, then they ask, well, if I'm pushing up, shouldn't my ankle change? Yes, your ankle will change and the tibia can come forward. Your leg bone can come forward because I always use spandex straps based on the weaknesses of the muscle. Most of the AFOs come with a rigid Velcro strap, and you cannot allow the tibia to move. Your tibia or your leg bone moves forwards, backwards, it turns in and it turns out when you are walking, sit to stand, squatting. So I use different tensions of ankle foot orthosis. Notice this one says Vel stretch, and it's 55% elasticity, while this one is a little harder. It's hard to push this one out. It's hard to push this one out. I have these in different colors and different tones, and I've been asking manufacturers to make these in flesh color tones also, if they have them. If your orthotist doesn't have them, you can go to a craft store and get these. Think about the elastic band that's in a pants around the waist. This is what this is. And it allows the tibia to come forward, because when you walk, your leg, your body weight comes behind you. You put your heel on the ground. It comes over you, mid stance, terminal stance, and then pre-swing. Your heel is off the ground and you're balancing on your toes. It's going to be hard to balance on your toes with this. It's flat. And so a lot of my AFOs have a transverse arch where the big toe is lower, because the last thing to leave the ground is your big toe to push off. And it has an arch here, and it has a little arch on the outside right before where your heel starts. That's your lateral arch under your cuboid bone. And so the purpose of the ankle foot orthosis is to pull the foot up. It's not to limit the leg from coming forward. If anybody watching this video should want to stand up, you bring your ankle behind your knee, meaning your leg is forward to stand up. For those of you who are stuck in an ankle foot orthosis where your tibia, your leg bone, cannot come forward, you stand up and you're rocking like this to get the force to come up, when all you have to do is this and go up. When you leave your foot, when your foot doesn't move from the hind foot to the midfoot to the toes and it's rigid, and your tibia cannot come forward, your leg bone cannot come forward, it weakens your thigh muscles and it weakens your butt muscle. And that's why so many people walk bent over like this, because their gluteus maximus, their buttock muscle, the big one, cannot work to keep you vertical and keep you upright. So that's what an ankle foot orthosis is. Helps to pull the foot up. It should not limit the tibia forward.
So the one you just described, those are solid AFOs. If someone has an articulated AFO, what's the difference in what you just described for them?
Okay, so an articulated ankle foot orthosis means it has a hinged joint, and it's either metal or a heavy plastic. And I stopped using those maybe 8 to 10 years after practice because, number one, they were too expensive. And number two, they didn't mimic what normally happens in gait. Just because you hinged an ankle foot orthosis doesn't mean the leg is going to come forward. The leg comes forward because of eccentric muscle activity in the posterior calf muscles, not because of concentric work of the anterior tibialis pulling the body forward. So just because you hinged an AFO doesn't mean your leg is going to come forward. And what I have found, that the hinge portion is too hard for the people to come forward. They don't have the power nor the force generation to move against the hinged in the AFO. So I remember getting a metal upright for a client, and the orthotist told me, well, that's what the doctor ordered. I can call the doctor and ask him to change it. The lady needs to be able to get her leg forward, and she cannot. So he made it from a U shape, rigid, to a free flex going forward. It had 180 degrees of freedom. And then we put it on her, and her knee just kept slamming forward. And he said, see? And I said, yeah, I see it. Her calf muscle's not working eccentrically. When you had it rigid and fixed like this, her calf muscles couldn't work. Now it's my job to train the calf muscle eccentrically to control the vertical shaft going forward. I didn't ask him for spring loaded. I didn't ask for dorsiflexion assist. I just needed the tibia to move forward. And I added a spandex strap to that. I got rid of that leather strap that came through the metal. I got rid of that also. Immediately, her daughter's first thing was that she stopped falling. I said, because I taught her how to do a suspensory reaction, which is a squatting. I wanted her to lower her center of mass towards her base of support. She was falling because she was teeling over. She couldn't bend her knee. She couldn't balance on her forefoot. I taught her all of that through the right exercise. So just because you make an AFO more flexible here or hinge it doesn't mean the muscles are getting stronger to control your body movement. So a lot of people hinge it because the leg is supposed to come forward. A lot of people don't have the muscle strength to pull it forward. And it's not a pulling forward of the tibialis anterior. It's an eccentric control of the posterior calf muscles that allows your body to come forward in that midfoot rocker. Another reason why I don't use them is that they're so wide and they don't encapsulate the heel. So your heel is just moving all over the place. And if you have a spastic equinovarus, it's probably not the best ankle foot orthosis for you unless you can cup and control the heel, and then the hinge is higher, and then you can do the movement. But the problem is your malleoli sits right above your shoe line. And if you have to get a wider shoe, are you going to get a wider shoe for, you're going to buy another shoe for the opposite foot so that fits your heel? And so that's why I don't do those. Most of my, no, not most, 99.99999 of all my ankle foot orthosis fits in the shoe that the person normally wears, and I take out the liner. So I always look, I said, bring me a pair of your shoes. I look at the outside heels to see if they're pronator or supinator. If they have a forefoot varus, meaning the front of the foot is turned in like that, or valgus, it's overpronated. Overpronated meaning the forefoot is in valgus. It just comes down a lot. When you're pronated, you've lost your medial longitudinal arch. But the forefoot is down like this, and you can tell if they have calluses on the side of their big toe. They don't necessarily have a valgus of the big toe, hallux valgus, but they have a callus from doing this all along the big toe. And so I look at the wear and tear, and then I take their outside liner out, and the outside liner will tell you all the weight bearing points of the foot. Therefore, you have all the weight bearing points in your AFO. And see, I've marked them where the things here. You can tell that this AFO has a different foot plate and how it's different.
Right.
And that's because of the weight bearing patterns of the foot. You don't want to change the normal weight bearing pattern. You need to accommodate the changes of the foot due to muscle weakness. And when you have a weak muscle, other muscles overwork, and they can change the skeletal form and alignment of muscles. And that's what you need to accommodate.
Thank you. Okay, so let's talk about the person who wears their AFO all the time. However, they want to have some time without the AFO on, without the shoe on. They want to be able to walk around their house. I always tell people that's not the safest option. But what is your take?
You wear the AFO, and then you put 3 fingers in between the spandex strap. I never use the straps that come through the loop and come back across. I put 3 fingers in there, and you need to practice walking with the strap loose. Practice squatting with the strap loose. Practice doing your exercises with and then you take the strap off, but you leave it, you tuck it behind, and you Velcro it behind. And now you practice walking and doing all your activities. I call it free form. Your leg is free to do whatever it wants, but it's still stable in the brace at the ankle part in the shoe. If they want to wean, sometimes I tell them to start with a high top shoe and then go down to a shoe that's 3/4, and then go down to a shoe that's right outside. I mean, that's right below the ankle joints, the medial and the lateral malleoli, the bones that stick out on the side. And sometimes, I have gentlemen, I'm a work, construction guy, and I only have these kind of boots. I say, well, then let's change the boots and have more flexibility versus rigidity. So, and then when they come to clinic, we're practicing stuff without the brace and with the brace on. And so when they come to clinic, I always take the brace off.
Got it. Okay. So generally speaking, we know that people can be prescribed an AFO, but how long do they have to wait before they need a new one? Or how do they know if a new one is even needed?
So when you take your brace off and you can stand and you can weight shift, move forward and move back, and you feel your muscles working, then that's the time you need to start weaning out. But how do they do that? Because you loosen the strap and you take the strap off. So when you can walk and pick the foot up and land on your foot, and your knee doesn't collapse forward or it doesn't hyperextend back, when you can squat down to the floor and squeeze and come up with your toes on the ground for the other leg, that means it's strong enough to support your body weight. When you can lay on your stomach, bring your weak foot forward and then push up on that leg. Because I always put the hemi leg in front first, especially if they have an extensor synergy pattern. You don't want that leg in the back. You'll never get it bent.
Right.
And that's a different thing. You know when you're ready, when your treatment plan is based on the diagnosis and the impairment of your leg. Folks who are low tone and floppy foot and have the drop foot and the foot slap, they are treated very different than the people who have the extensor tone, the stiff knee gait with the foot pointed down and in. Whole different treatment pattern. And I go to people's homes and they get the same exercises that everybody else gets. So again, I think that's why my clients are improving faster and differently, because I have a pattern based on the stroke lesion, the severity of that lesion, and how large it is. And large meaning, did it go into the sensory part of the brain? Did it go into your frontal lobe of the brain where you make executive decisions about safety?
Yeah.
See, all of that matters. And so we change up how we do the exercise program and the treatment interventions and the physical activities. Exercise is different from physical activity. We need to differentiate the two. I have a lot of people who don't even own a pair of sneakers. They ain't exercised in their life, but they engage in physical activity. So now how can I make the physical activity an exercise that is therapeutic, meaning it has repetition, it changes in intensity, and I have to go through layers of isometric, concentric, and eccentric muscle activity at the body structure function level, but then engage those muscles at the activity level. And the activity may be standing up at an ironing board and ironing. It may be washing dishes at the sink. A housewife, the traditional housewife, she ain't going to Pilates and yoga and exercise class. She's doing things around the house, carrying a laundry basket, dusting furniture, folding clothes, putting them away in a drawer that's on the bottom floor. So the program has to change based on who the person is. So again, I determine when they're going to get out of the AFO and when they can start doing things different based on my measurement. And the things that I'm measuring, strength, and the strength in different ways, because I don't think we measure that. We don't measure functional strength, and range of motion, balance, neuromuscular, and then cognitive. What if you come to a 6-inch height step that has no rail? Can they figure that out? What are they supposed to do? Right? What if they come to a door that opens inward and they have packages? Can they figure that out? So that's when they're ready to change and move and advance. And for a lot of my AFOs, they start off tall because they needed the support. And then as the calf muscles get stronger, the knee muscles get stronger, the butt, the AFOs get shorter and shorter. So that's another way then they're ready to change. And I don't always buy new braces. I don't always get new braces. We modify the ones that they have. Cost issue. But if they have to get a new one, I have a letter of medical necessity with all the terms based on my measurements, functional outcomes, standardized tests. And I say the person needs this brace now because this has changed. If they don't get it changed, they're at a risk of developing this or that.
Got it. So, we work with, or I do, a lot of people who are older, and they will have had a stroke multiple years ago and get the initial AFO then. And so I'm probably seeing you maybe a few years in. And so they are wanting to know, like, is there a time change that we should consider when we're looking at, can I get another AFO?
No, Medicare says 5 years. Don't believe that. It used to say, I don't know what the term is now. You get a new FO when there's a change in function at the body structure function level, or at the activity level or the participation level, meaning your role in society. So if you get a new job and you got to walk 5 miles a day in the plant, you need a different AFO that's going to be able to tolerate walking on a cement floor in some boots for 5 miles a day if you put in that many steps a day at your job. That's different from the AFO that you wear at home to stretch the heel cord out when you're in bed. Because some people wear their AFOs at night to stretch out their foot in bed. And so it's different. It's different.
Right. Okay. Are there any tips? I know we touched on it a little bit for someone who's buying 2 pairs of shoes because they need a different size for each foot because they're trying to accommodate the AFO.
Ask the vendor if they have any last year models that are on sale or cheaper price. But my thing is, you shouldn't be buying 2 pairs of shoes. If you go to my YouTube, I think, I forgot the name of the title, but it's at JVBNEUROPT.com. I have I think it's less than 5 minutes, a video about changing the AFO so that the person doesn't have to get a larger size shoe. And I think I have a picture on there of a person that has 2 different shoes on her feet. And I was like, this is totally unnecessary.
Totally Give me the link again.
It's at JVBNEUROPT.PT. That's it. YouTube. So it's my initials, JVB NeuroPT. Yeah. That's it. And if you go there, I have a whole bunch of videos. And I know I did one recently. And I had one of a physician. He wanted to wear his in his floor shine shoes. I could stick my whole finger down in between his foot and the AFO wall. So that means he had to get a wider shoe. But he also wanted to have that same AFO fit in his sneakers so he could learn to run. He wanted to learn to run again. And I'm proud to say I ran with him on the beach.
And that was even harder.
And that was harder. It was a different. And see, that's what physical therapists aren't doing. We're not practicing walking or gait training on different surfaces. You got to think people have hardwood floors in their homes, linoleum. They go outside to their patio. There's blocks. There's gravel. They got to walk on grass to get to the mailbox. So I'm all about
vacation.
Right. And they go on vacation. Right. They go on vacation. And so I'm all about surface training. See, people call it gait training. I'm about surface training. Can you train body reactions, ankle strategies, hip strategies, suspensory reactions, equilibrium reactions on different surfaces? Everybody's in the clinic walking. Okay, we got to walk around this perimeter and they don't even change directions. How about let's change directions sometime? I remember being at a facility and I think I was PRN or something. The guy, he said, you're walking in the wrong direction. I said, no, I'm not. The person has a visual neglect and they have a heminopsia. I need to walk in this direction to have them turn their head so that they can see the peripheral different. And then, okay, just... No, I'm not walking in the wrong. I'm doing what's right for the patient. We need to do person-centered treatment.
Yep.
So again, just to end the story, make sure you are training on different surfaces for the circumstance of walking. That's what you need to do. Yeah.
Okay. Last question. What advice would you give someone who has had a stroke with the resultant foot drop, but they cannot get access to an AFO?
There are a lot of things you can do. You can go online and you can get something that attaches to your shoe and then you hook it into the laces and then you pull it up and wrap it around your ankle. I had a gentleman who made his own foot pull-up strap. He just took his sock and then he put a rubber band, a thick rubber band, like, you know, the thick ones like you can get on a bundle of something. He put it up top and then folded his sock down and then added a strap from that rubber band down to his shoe. And he didn't mind because he was a male and he wore pants. I use TheraBand to hold the foot up, ACE bandages, people who are proficient in rigid taping or kinesio taping. There are a lot of things that can be done. I have traveled with my own thermoplastics. I go to a person's house. I make like a little U shape, and then one for the sides and one from the front of the foot up the back of the Achilles tendon. I heat it up. I mold it to their foot. I put a liner in there. I wrap it. I give them one of these spandex straps. I've done that. I have fabricated a, okay, so I'm showing my age now. I used to use plaster of Paris. You know, you put it in the water. Yeah. And now I use a fiber. If I have to do it, I use a fiberglass. And I've just made those in 30 to 45 minutes in a person's house, shape it on them. And now they're walking with a trial. As a matter of fact, I did that for a well-known person here in Charleston. And I told her, now you take this brace to the orthotist and tell him this is the prototype, because that's what I do. I make them for the folks and I tell them, take this to the orthotist, and I can meet with the orthotist, which I've done. And we've all had a team meeting because I believe in a team approach. And we're going to make the brace. This is the prototype. It has to look like this. If you look at the process by which an orthotist makes ankle foot orthosis the traditional ways, you'll understand why they don't fit like a glove to people's legs. You'll get it. And I've been the person who's been scanned for my orthotic, and AI and technology is nice, but when you're scanning, it doesn't pick up the nuances of your foot, like the strength, the range of motion, the difference between the hind foot and the forefoot varus or valgus. So I have some orthotics now that were scanned for me, and I don't wear them because they just don't fit well. So you're nuanced of knowing the impairments of the leg, foot, and ankle will make you look at things differently and fabricate or tell the orthotist different recommendations for a different AFO. In the meanwhile, strapping, ACE bandage, TheraBand, taping, all of those things work. But you know what? We are creatures of habit. We don't want to look like we have a contraption on us.
At all.
At all. And I was amazed because some people just want to walk. I was at an airport in the north, and because I'm always looking at people. That's why I'm so good at gait analysis, because I look at people walk. She had on this ankle foot orthosis that had this curvature like a C. It was a carbon fiber one. And you could tell it was limiting her because she would take a quick step forward, her whole pants leg was rolled up on top of the ankle foot orthosis. And I'm thinking, the PT or the OT didn't tell her how to split a seam in her pants, add a piece of fabric so she could have a wide leg and then do the other side and it would cover the AFO. You know, sometimes I tell my clients, if you don't want to wear your brace and you're having the knee snap back, get a heavy duty tension band and cut it the width of the pants and then sew it in on one side, sew it into the other. So that'll keep your knee forward in your pants leg. Now you can't do this with skinny jeans, but you know, a straight leg pant. And I tell them that, and they was like, oh, you know, that idea worked for me. I said, great. So there are a lot of things that you can do. And if you're not able, you can just, you know, I hate small, medium, and large, but just go online and see what there is small, medium, and large. But then you need to have the information. Do I need more stability at the ankle? Should my AFO come up across the ankle? Am I supinating, or is my foot raising up and my tibia rolling out? That means I need a wall to come further forward on the outside of the AFO versus the inside. But if they go to a physical therapist and I'm leaning over here to get a book. In my book, I have the entire physical therapy examination that should be done. A lot of people just say you're going to get casted or you're going to get seen for the orthotist for an AFO, and they don't give them any measurements. Nothing about tone, spasticity, mobility and open chain and closed chain. I was talking to someone and I said, did your PT measure your ankle laying on your back, sitting down, and standing up? Oh, I don't think so. Well, you wear the AFO standing up and walking, and you have to go from sit to stand to get up. So you have to have the flexibility at your ankle. And if you don't have the flexibility of your ankle, they put those cross straps and to force your heel back. And the people said, I didn't wear it because it hurt, because my ankle kept coming up against the strap. That's because you don't have enough range of motion. So what are you doing in the treatment program to improve the range of motion? So again, I will close with that question, that there is a lot of options that you can do if you don't have access to an ankle foot orthosis. You just need to know something about your foot and ankle.
Absolutely. Well, I want to thank you so much for sharing all of your wealth of knowledge and how you're making it practical for those of us who are at home and possibly having this issue, or even for the therapist that's watching. So is there a final thought you'd like to share?
Final thoughts. If you don't know, have the courage to ask the questions. And so in my book, I have 2 chapters of all the questions you can ask the physical therapist and the orthotist. Read for your understanding. I have a column in Lower Extremity Review magazine, and I've tried to write for the spectrum of the person, whether you're a lay person with a stroke, if you're a healthcare professional, like you're a surgeon. I want you to see the perspective of things that we need to do differently for the foot, so that we can improve health outcomes. Remember, when you go to physical therapy, just don't go to fix the problem of the stroke. The problem of the stroke, the resulting impairment that you have, may not get better because of the lesion severity. How many of the neurons were destroyed by the stroke? You need to go to the physical therapist with a picture of what you can do for better health for your lifespan. And that's why I call it health span. You may have to look at nutrition. You may have to look at your sleep habits. You may have to look at your stress level. You may have to look at exercise for the function in your home. If you live on a second floor walk up, a lot of your activities should be doing with verticality and having to walk up and down those stairs and being able to get up off of a floor, because you need to generate force power. So really look at rehab for your overall health outcomes, because I have people doing things. I go to people's homes. They have braces, gadgets, and all of these things in the closet. And they said it didn't work and it didn't help. But then I asked them, well, how's your health? And so we need to focus on exercise and physical activity to improve health. Then you can prevent a second stroke.
Absolutely. So how can we connect with you if we still want to ask another question, or we want to learn how to purchase your book? How can we connect with you?
My website is www.jvbneuropt.com and www.jvbneuropt.com. And there's a tab on there for the book. The book is at Amazon, Barnes and Nobles, Walmart, Target, at all of those vendors. I have a YouTube channel at jvbneuropt.com. I'm on LinkedIn, Dr. Jennifaye V. Brown. My email is info@jvbneuropt.com.
Thank you so much. So if you are interested in learning more information about ankle foot orthosis and from Dr. Brown to get all the information that she spoke about, please contact her on the ways that are on the screen. Thank you so much for joining us. As always, Pull Up with Limbs and Things is to confirm something you know, to challenge something you don't know, and to give you the opportunity to share this information with someone else. We'll see you next month. Have a good evening. Thank you, Dr. Brown.
Thank you for having me.
Absolutely.